This conference will now be recorded.
This is the AnCan High Risk Recurrent Advanced Prostate Cancer Support and Discussion Group for Tuesday, 10/24/23. We're going to start in just a minute, but first I just wanted to acknowledge some of our sponsors, none of whom are requiring us to in any way favor their products. So we're free to say anything we want. They're just giving us, helping us uh, pay the bills. And they are, is Pfizer still on our list, Rick?
We hope so, but we're not sure.
I'm not sure. Okay. And we got, correct me if I have any other ones wrong. I have
Yes,
Myriad Genetics, Blue Earth, Foundation Medicine, Telix. Is Bayer still on our list?
yes, definitely.
Good. Bayer is still on our list. Janssen, J&J Pharmaceuticals, and Myovant Sciences. So, I was expressing a little bit of concern for that large number of newbies last week, Rick, uh, all of which are not here this week except for Chuck. So, but he told me we weren't too scary last week, and he didn't think it was he didn't think it was our fault. So, I don't have any newcomers to interview today, and so we can relax a little bit about time. We won't be under nearly as much pressure as we were last week. And I'm going to go right back to what we started with Boykin's situation regarding um, how he's a Gleason 9 who had seminal vesicle invasion, but is uh, um, concerned about radiation treatment because he has a kidney transplant, and as he was just saying, has to protect that kidney at all costs, making his decisions more complicated. So let's go back to right where we were, okay, Boykin?
Okay,
Boykin?
okay. Want me to continue?
Yeah, please.
So the other thing I also kind of realized in coming into the first session is that I didn't know enough about how to read a pathology report. And so when I went back and I started talking, I found out I don't have seminal vessel invasion.
Oh.
Right,
Okay. Okay, so you are entirely localized.
right. And that's what they said the PSMA scan showed is that it was entirely localized. No, no perineal duct. It was just all in the prostate gland. But then, if I didn't do anything, it was going to spread. If I just left it alone, it
And
was
that
definitely going to
prediction
spread.
is based on your high Gleason score.
Yes, yes. And so I just felt like at the end, I have to protect the transplanted kidney and any type of treatment that would could interfere with that or prevent me from getting another kidney transplant in the future because of residual scar tissues or any of the other stuff, that wasn't a risk I was willing to take. So then for me, that left only one real treatment option. And
And
so
then how did you deal with the question of hormone therapy?
um, that's always a possibility. But if I'm not metastatic, then why would I do that route? If
Well, I
that's
think
like for
that's a
12
good
years,
question for discussion.
right? And I looked at it and said, from kind of the support groups that I joined in, that didn't seem like that was for me at least, a fun way to live life because I'm only 61 and I wanted to travel and do other things and I wanted my energy for all of that stuff. So I just kind of decided it's better just to get all the pain and agony over with early and then see what happens. There's no guarantee that it won't come back, and I know it may not even be the right decision. in the long run, but at least in the short run, it made sense to me.
Uh, Rick, I think you'd like to open this discussion, would you?
Sure. Um, I'm curious. Did they change your staging then to a T2B?
Well, that's actually what I was.
Oh, you were T2B.
Yes,
Okay, because I thought you were a T3A, or T3B rather, based on the seminal vesicle invasion. I thought you were T3B based on seminal vesicle invasion, but that was just an error. You didn't have SVI. My question, a couple of questions. The first is, did you get to meet with Channing Palla?
no,
Okay, because you don't feel it's necessary now. Is that the reason?
that was the reason why. Yeah,
Okay. No, I mean, look, if you're still high risk because you're a 4+5, that immediately makes you high risk.
yep,
But given
absolutely.
but given the situation that um, because of the position of this extra kidney that you have, radiation becomes a lot more difficult, and so you're going to go the surgery route. Yeah, I get it. I mean, I can see why you don't need to be really with us anymore because you ain't going to get hormone therapy. You are going to get surgery. Of course, we'd love to keep you here and keep talking to you, but I do think
Right.
it's really important that um, you talk to the guys in the low intermediate group who have the surgical experience. Although we have quite a few guys in here who have surgical experience
Right.
too, and
Okay.
they'll tell you what to expect and they'll give you some tips. I'll send you the tips package that is pretty helpful. Are you staying with Dr. Chestnut and going to do it at Walter Reed?
Yes, yes. I already did it.
You had your
I already,
surgery?
yeah, I had the
Oh,
surgery on October the 12th.
oh my gosh. How are you doing?
I feel good now. The first few days was terrible.
Yeah.
Yeah, I found out I'm not when they. I thought I would recover faster than I have, but then I had to realize that well, okay, I'm thinking like I was in my 20s, but I'm in my 60s, and so it did take me longer because I found out that I have a back issue and some other things. So the recovery overall wasn't the post part wasn't did not I was over optimistic as to how fast I would recover from that. But I'm feeling better now, and I'm starting to slowly about 2 weeks to start to get out and walk about and put on the watch. I just had the energy today just to say, okay, I can chime in and do things and start to return to some normal activities. But I'm going to
Well,
have another 4 weeks before I think I'm physically
yeah.
back to where I was at. Yeah.
You be careful. I'm gonna let some of the guys who had surgery chime in a sec, but you be
Okay.
careful because it's very easy to get a hernia. It's very easy. You can't do any heavy lifting. Those surgery guys will tell you all of that. So you're amazing. 11 days out, it is like nothing ever happened. Is the catheter out?
Oh yes, they took that out last Thursday.
Okay.
So,
Okay,
but
Dr. John, back to you. You know about surgery.
Yeah. Well, this surgery was actually, despite having a 9, this surgery was an attempt at cure, right?
right.
That's what we're hoping for. It's an attempt at curative treatment. Um, I don't know. So you're going to have another PSA in about a couple of weeks, right?
Yes.
And that'll be your first one.
That'd be my yes.
And then another one at 12 weeks or something like that.
Yep.
Okay.
I have a 6 week follow up, and then a 1 quarter, like 13 week, and then after that, 13 is a whole year. But what I'm trying to say is, after the 6 week follow up, all the other follow ups are quarterly for the first year.
So let's prepare ourselves for that 6 week follow-up PSA. Tell
Okay.
us
Yep.
what it's going to be like for you when you get the results. What do you know about what the results mean and everything?
Well, I think what I heard in the group and what I've heard in other groups is that my PSA should be like non-negligible, able like
Right.
0 to like, I think they say like 0.2 or 0.2, something like that.
I think it
And
maybe should be even lower than that. I don't know. Shouldn't it be
okay,
non-detectable at all, guys, or what?
Yeah.
What are we hoping for this 6 week PSA?
Well, we're hoping for less than 0.1.
right, 0.1.
Yes.
Okay, thank you.
Less than zero point
Less
zero
than.
one.
Yes.
Oh, it's 0.01.
Yes,
Yes.
less
Less
than that.
than. Got it. Okay.
And then you're going to have one at 12 weeks, and then we're going to know whether it's higher than the 6 week one or not. Gary, do you want to
Okay.
comment?
I was just going to say that sometimes 6 weeks is early to get it to non-detectable.
Oh,
Um,
is it?
and they really look to the 12-week result as the more telling. So if you still have some residual at 6 weeks, uh, you don't necessarily have to panic.
Okay.
I I had a significant residual, but that's because of issues I had.
Okay.
My PSA was 0.06 at 6 weeks and 0.17 at 12 weeks. So it was clear where that was going, and I started on hormone therapy at that point.
Okay.
Look,
And I
I
guess that's
have to
going to,
say, this is not a great group to be asking because there's a lot of recurrence in this group. And so there's a good number of guys who are here because they didn't get what they wanted from the surgery. So we don't want to discourage you, Boykin.
Right.
If you ask the guys in the low intermediate group, you might get a much better response than you will in this is what they call a pre-selected
yeah,
sample or a biased sample.
we're not a
Well, no, I know,
representative sample.
but I understand that. That's why I like the option you gave me to also go to the low group too,
Yeah,
um, to the other group. I mean,
yeah.
I mean, I'm gonna say out of the whole thing, the biggest takeaway I took from coming in my very first session and getting the feedback is that I needed to think through the treatment plan as a chronic disease, like a lifetime thing. And I kind of said, if I sent garbage information in, then I got garbage feedback. And when I was talking to my wife, I said the one thing I'm absolutely 100% positive of is everybody in the group was trying to help me based on what they believe they heard me report in. And if I did something wrong, then I got the wrong advice back as a result. But then I also said I also have to balance the perspectives of the group against other things.
Correct. Correct.
Mhm.
Correct.
just want to take a second here to return a message to Rick, and then I'll be right back to you.
Okay.
I think you did the exact right thing for you. I can see on your face the level of relief on your face. So you did what was right for you. You know,
Well,
and it
thank
was a
you.
ballsy move, and it was a ballsy move. You didn't hesitate, didn't wait too long. So good for you. Good for you.
Mhm.
Okay.
Thank you.
Anything else for Boykin? We just don't know yet, but we're going to know a lot in a few more weeks, and I hope you're still coming to tell us about it. And I
Yep.
think if you're non-detectable at 12 weeks, then Rick will throw you out of the group.
Oh, okay.
No, we never throw people out, but
No, I'm just kidding.
no, but I will say, because it sort of has happened to us a couple of times recently where we've had people listening to us who have not been as advanced as the tone of the group, and it's concerned them. And that's the reason why we don't have mixed groups, because anybody's welcome into any group, but sometimes if you put lesser advanced people in with more advanced people, it can create anxiety. So we're sensitive to that. So that's the only reason why. But Colonel, you're always welcome. You know that, and I'll make sure that you're. In a second, I'll just make sure that you're signed up for the low intermediate. It'll take me a minute. We have Jim Marshall wants to say something before we leave you, which
Yes.
we'll handle. But we have a telephone person other than John Kish. Would you like to identify who you might be? Not John Kish, somebody else.
Are you referring to me, Henry?
Oh, it's
Yeah,
Henry. Hello, Henry.
How you doing, Rick? How you guys doing
Okay,
tonight?
good.
we're all doing well. Henry is our retired police officer from South Carolina, but he wasn't a police officer in South Carolina. He was a police officer in New York City, right?
Upstate New York, Syracuse.
Up, oh, Syracuse. Oh,
Yes.
do we have our Syracuse people in tonight? No, we don't. They might come in later. Okay. They'll have to behave. All right.
Henry,
Jim,
Henry, are you? Oh, I'm sorry, Rick. Go ahead. Call on Jim.
Oh,
Jim Marshall.
Jim,
yes, yes. Colonel, and the next hurdle you will have shall be the VA, and we can chat about that.
Okay, that sounds great.
Okay, great.
Absolutely. I'm supposed to talk to them in 2 days.
Yeah,
Okay.
Jim, go ahead and make an announcement about Thursday's group as long as you got the floor.
Yes, and with the VA group and where the veterans happen to meet on this Thursday, I believe 8 o'clock, okay, in this room. So come on down if you are a veteran. There is money to be made, trust me. You earned
and
it.
that's right.
You
And
earned it.
Anne can only ask for 10%. That's all. Okay. But yeah,
And
we
thank you, Rick, for correcting my facetious remark about kicking him out of group. It was just that
no, 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 no,
we
no. Nobody took it seriously. We didn't take
yeah,
that seriously. We knew what you were saying. Absolutely not. Absolutely
we
not.
all want to be kicked out of
I
this
didn't
group,
take
I
that serious
guess.
at all.
And that's kicked out vertically, right, not horizontally.
Yes, thank you very much.
I think it might be. This is a virtual group, so it might be in 3D that you get kicked out, Kurt. I'm not sure.
Into the fourth dimension or something. Henry, are you going to want to bring up anything tonight?
Oh, I don't think so. I'm just want to listen to you guys and get some of you guys' wisdom. That's all.
How about you, Gary?
Um, no thanks, John.
And how about Mark Valens?
If there's time, I'll give you an update. I've got a lot going on, but if not,
Okay,
it can wait.
I think we're going to be able to get to you. Okay. Boykin, I think we'll go on to the next person unless you got any lasting questions.
No, I'm good for now. Just listen. Thank you.
All right, good luck. Jim Ward, please.
Hey guys. Um,
Hey.
so I think most of you all haven't heard a whole lot from me in a long while, and that's because I've been backbenching it for a while. And as some of you know, that's mainly because I've been on a drug holiday that's been pretty extended, so I haven't really needed much time. I'm approaching 3 years, so I know I'm very, very lucky to have been off the medication for that long. For background, for some people who don't know my journey, I started the drug holiday in January of 2021 after doing 2 years of ADT and some IMRT radiation in conjunction with that. Took a year to get to 0.1 with the PSA, and then since then it's been bouncing around in the 0.1 something to 0.2 something range. But all good things have to come to an end. And a week ago, I crossed into the 0.3 threshold and actually tested at 0.370. So I feel like that could be a significant uptick. And so I let my GU MedOnc know about this at MD Anderson in Houston. And we've agreed that I should get an updated PSMA PET scan, since I've only had one before. That was in July of 2022, so almost a year and a half ago, and that one was clean. And I think at that point in time, I was at about 0.2. So we'll see what it shows and decide where we go from there. Mainly just kind of sharing this update with you guys. I think if I need to reinitiate ADT, I've got to, I may have a tough decision. Again, it all depends on what the PSMA PET shows, but anybody could probably guess that I'm reluctant to go back on the standard ADT, testosterone suppression, certainly, because like I said, I've been through it for 2 years. I know almost everyone on this group has been through it, or you're going through it, so we all know what that's like. I tolerated it okay, but I think I may or may not be at a decision point where I might go back to what worked, which was Lupron and Zytiga, or maybe explore the possibility of monotherapy with darolutamide, which I know has worked out well for quite a few guys. And that's kind of where I'm at. So I don't know when we're going to do the PSMA PET, but we're going to do it as soon as we can. And I'll certainly, share the results and kind of give folks an update at that point. So I don't know if there's any thoughts or comments, but I didn't really come to the group with a question. It was just more to kind of provide an update that I haven't given in a long while.
It's a very important update, and you're at a potential turning point in treatment now. Gary has a comment for you, I think.
A question, Jim. I missed what you said at the beginning. How long have you been off everything?
I have been off everything since January of 2021. So I'm about 2 months shy of being off everything for 3 years. And I know I'm incredibly lucky, and, can't complain about that. I thought I would do well if I got a year out of it. And that was my hope out of the gate.
Right.
And I know that statistically speaking, getting close to 3 years that's pretty darn lucky. So I'm very grateful for that. And, but yeah, most parties have to end at some point.
Yeah.
How strong was your T recovery?
I got it back within 4 months. Within 4 months, I was in the 300 range, and ever since then, I've been consistently in the 400 to 500 range. I would say the average has been somewhere in the 400s, an
And
occasional uptick into the 600s. So I've been very fortunate with that. But I mean, I'm a little bit younger than your average bear in this group, so that probably had something to do with it,
you
I would
young
guess.
macho guys. Yeah.
I've never been called macho in my life. No
Well,
reason to start now.
in this group you are because you got a T level of 500 or something like that. And you've been feeling good and you're really loath to give that up.
Yep.
Jim Marshall, you got your hand up still? I can't.
Yes, I got my. What kind of a Gleason score did you have in the beginning?
In the beginning,
Yeah.
my highest Gleason score was a 4+4, so a Gleason 8. And then the others were a smattering of 6, as low as 6, and a couple of 7s. So I would say I just, it seems like the consensus was call yourself an 8, because that's the highest that came in. And at time of diagnosis, I was a PSA of 210.
Oh,
At age 52 going on 53. So yeah, pretty alarming.
What
And
about
some
Wow.
people,
mutations?
no actionable mutations. I had both genetic tests. Actually, I'm so glad you brought that up, Jim, because I would be interested in this group's opinion about whether or not it would be time. Well, I'll answer your question first. So I had the genetic testing done right out of the gate. There was nothing actionable. I had somatic testing done, probably about a year into the journey. That didn't reveal anything. And so now I'm thinking would now be a good time to get, say, a liquid biopsy, if nothing else, just to kind of see if there's been some change or some evolution. I don't know if people have thoughts about that.
Yeah, well, the first thing that you need to do, if you're even considering it, is find out where your insurance coverage stands. Because you're not yet on. You didn't take SSDI, did you, Jim? I can't remember.
No, I didn't, Rick. So I'm on my wife's insurance. I
Right,
kind of went into semi-retirement not long after my
right.
diagnosis.
Who carries your wife's insurance?
Blue Cross, Blue Shield.
Okay. Some of the insurers are not covering. So we just found out, for example, recently that you can have a big problem with United Healthcare. So before you even think about it, find out if it's covered.
Okay.
Then, because you may find yourself in a situation where you can get it, but you're going to have to apply either for financial assistance with the company, or you're going to have to pay for it out of pocket. So that might be a factor for you. I don't know,
Mm.
but that's the first point. Um, would I get, if it were me, would I get it right now? I think I probably, first of all, would see what the PSMA scan says and if there is something there, where it's coming from and how we're going to handle it. Because if you decide initially to handle it with, say, spot radiation plus some type of hormone therapy, I'm not sure that what you're going to learn is going to change your decision. I mean, the only thing that might change that decision right now is if you came back with a somatic BRCA, and so you were immediately immediately a candidate for a PARP. But I don't even know if you'd want to do a PARP at this point in time. So I think you got to speak to Dr. Korn and ask him whether he thinks there's a point in doing it now, because if he doesn't we always say don't do a test unless it's going to make it's going to have an impact on your treatment. To do a test for the sake of doing a test, I'm not sure makes sense. That would be my input.
Okay,
At the
thank you.
heart
That
of
no,
this
that
question,
makes sense.
at the heart of this question is when a person is in the hormone sensitive space, like you are, right? Presumably you are, um, because your PSA is on the rise while your testosterone level is high. So therefore, you are presumably still hormone sensitive. So when someone is having a recurrence in that space, is that recurrence due to a mutation? And how many cases is that recurrence due to a mutation? Um, Maybe Len or Rick know, but I don't know the answer. But I would, if I had to guess, I would say it's not very many that are due to a mutation, a somatic mutation. I kind of would expect those kind of things to happen later on in the castrate resistant time, but and that there would be very few mutations that would be missed by not having a somatic test. But Rick or Len, do you guys know?
Well, I can tell you from personal experience, John, that I had 7 somatic mutations on diagnosis, and I was certainly hormone sensitive at that time. So you don't
But
have
you,
to be castrate resistant in order to develop somatic mutations, if that was your point.
well, I was thinking more of, I guess I was thinking more of new mutations because we already know he didn't have any mutations when he got diagnosed. I mean,
That I've had,
our mutations when we get diagnosed, like I have that SPOT mutation, like Jack does, those mutations at the very beginning probably sort of are our cancer. You know, they're not something that came later. They they are the very cancer itself at the beginning. I I, I just don't
So,
know if he needs a genetic test now or not.
well, they now throw around numbers which sort of surprise me, which is that as high as I think it's 17 to 19% of men carry mutations, but that includes somatic mutations. The the number of men carrying germline mutations is way lower. And Len can correct me, but I think I've seen anywhere from like 2-3%, and depending on how it's defined, maybe as high as 7. But I'm never really clear. So the question that tells us that you get more mutations as the disease progresses, which is a no shit Sherlock. We know that. Um, it's hard to say if Jim didn't have mutations, somatic mutations, when he first tested. Well, logic would say probably not much chance now because he hasn't been on a lot of medicine since then. He was on a medicine for maybe a year later, and then he came off. So the cancer isn't really hasn't had to respond, and the somatic mutations usually come in response to treatment. But I mean, again, this is the conversation to have with Paul Korn. Len, do you know what's the right number for how many men have carry germline mutations?
I would probably agree with you, Rick. I think somewhere between the numbers you gave, 3 and 7%, probably more toward 3 than 7.
Yeah.
Pretty low.
Yeah. Well, I think that all makes sense, and I appreciate kind of helping me center this issue of whether or not to get a liquid biopsy. I mean, probably no big surprise here, but even before this uptick, Dr. Korn and I have just talked kind of theoretically about, well, sort of if, but more likely when we reach a point where we have to take some kind of action, what's that going to be? And he has seemed pretty convinced. We are going to have a chat next week, by the way, so I may have an update after that. But he's always been pretty convinced that since I responded pretty well to the hormone therapy, that I should, he would expect that I would respond well again, and maybe set up a future drug holiday that I think, as we all know, maybe probably wouldn't last quite as long as this one. But that's kind of what that's been my main takeaway in talking with him, purely theoretically, is I would go back on some form of ADT, and what form that will be, I don't know. But remains to be seen.
So there's another important point that I didn't pick up on, but it just occurred to me, which is that you likely wouldn't show much on a liquid biopsy because your PSA isn't high enough and you don't have existing metastasis. So, we can do a liquid biopsy with a man with low PSA if he has a tumor burden, because there's there's pieces of tumor breaking off and swimming around the bloodstream. But usually when you have recurrence and you have a very low PSA and we don't even know where the mess is, we don't see much of a result unless your PSA, I want to say it's higher than 4. I haven't had to think about this for a while, but it has to be fairly high. And I think the number is 4.0. And we've done this enough times with guys who have had lower PSAs and they don't get a result out of a liquid. And it's certainly a 0.37. I wouldn't even expect you to get a result. So if you were going to do a somatic, it shouldn't be liquid. It should be a biopsy from whatever they see.
Yeah, which is a good point. I mean, for anybody who's sort of taking notes, at the time I was diagnosed, I didn't have any bone mets. I just had 3 or 4 lymph nodes, and those were treated through the hormone therapy and, of course, through the IMRT, pelvic girdle radiation. So those lymph nodes shrank. Anyway, for what that's worth, I think no, this is very helpful. I'm not seeing, and I will definitely talk to Paul Korn about what's the point or what's the value of doing a liquid biopsy now, because I'm beginning to hear that there may not be much of any value.
It also sounds like, although you're dismayed about it, that you would probably be willing to go along with it if he says it's time to go back on hormone therapy of one form or another.
Yeah, that's fair to say. I mean, reluctantly, but honestly, John, I tolerated the ADT about as well as anybody could. I mean, very minor hot flashes in the beginning, and those subsided, and I never really experienced them again. I mean, I dealt with the one common denominator that we all do, which is just battling fatigue, and I've embraced, exercise and diet and, strength training, the whole bit, and that got me through it. And so I know that at least for 2 years, and this was, certainly with a lot of encouragement and support, when I was tempted to cut that short a little bit. But the solid consensus was that you got to give it at least 2 years. And so I went with that, and I'm glad I did. And I was able to tolerate it. So if that's what Dr. Korn says that he thinks I should do, I'll do it.
That'll be a good time to talk with Len about some of his experiences with monodarolutamide.
Oh yeah, no, he's the kind of the superhero of that, and
yeah,
I think we all sort of dream of wearing that cape if we can, and we'll thoroughly explore that. I'm sure.
Okay, Jim, I think I'm going to go on. Does anybody else have any last comments or anything for Jim?
Well, thanks, guys.
Chuck. Oh, you're welcome. Chuck? You got the floor. Unmute, please.
Okay. Hi, guys. So I think I mentioned last week that I went through the 10 rounds of chemo, and which it didn't really do too much for me. After I stopped, my PSA started to climb, and I had a PSMA scan, and it showed the lymph nodes in my abdomen were getting worse and bigger. So they suggested going to Pluvicto, which I had a consultation yesterday at NYU to discuss, the treatment, and I talked to the radiation doctor, the woman. She was a woman, Doris Leithner, and she had the PSMA scan up and showed all the lymph nodes glowing and my prostate glowing, and she said I was, based on that, since I was expressing PSMA, in the lymph nodes, that I was a very good candidate for Pluvicto. So, but and then she went over the side effects of the treatment, and I'm just, I guess the primary side effects were fatigue, dry mouth. I guess when you do the treatment, it attacks your salivary glands as well as your tear ducts. So your eyes get very dry and your mouth gets very dry, which can cause, problems down the road. You could, your teeth can fall out, or you have teeth problems, and, other problems. So I'm not sure if anybody, this drug is so new. I asked the doctor, my wife and I asked her, what, is there anything you could do during and after the treatment to alleviate some of these side effects? And you know, in the doctor, the radiation doctor, really didn't know, because it was so new. But my wife did a lot of research, and she found that
So Chuck, I
yeah.
want to interrupt you because you've come to the right place.
Uh-huh.
It just so happens we have people with extensive experience, direct experience. Some guys sitting in this room right now have had already 2 or 3 rounds, each round
Okay.
being I don't know how many. So we know what you're driving at,
Okay.
and we can talk to that. And I think we should start with our Latimer, because he's probably the most experienced of the lot. And I don't know if anyone else in here has, but we've got plenty of guys who have done it. And we can connect you to those guys. And mea culpa, Dr. Bob has written a paper on the dental effects, which is sitting in my inbox, and I'm supposed to make a blog of it, and I haven't done that, but I promise I will. So make sure you sign up to our blog, because as soon as you sign up to the blog, when it gets posted, you'll see it, and we'll also include it in the reminder. But let's go with the and forgive me for interrupting you, Dr. John, but it was just such a beautiful opening for Al. Go ahead, Mr. Latimer.
Chuck, okay. What's your PSA right now?
It right now it's 0.6. After I completed the chemo, it was 0.1, and then it rapidly, after 3 months, went up to 0.6.
Okay,
So
so your PSA is still really low. My
yeah.
my PSA got up to 66. Let's see, when was that? That was the middle of 2021, and I started Pluvicto at that point and did the 6 sessions, and my PSA dropped to 1.
Oh,
Now,
okay.
um, and you mentioned dry mouth. Yes, the dry mouth, by the time I got to the 4th session, the dry mouth was significant. And by the time I got to the 6th session, it was pretty severe. But in a couple of months, it recovered.
Okay.
I have not had dental problems. As a matter of fact, I had a checkup yesterday and they told me my gums and my teeth all look very good. So I haven't had a problem with that. Um, On the other hand, my PSA started going up immediately after I stopped. And before I knew it, my PSA was 66 again. And I did chemo. I did 8 rounds of chemo, which you've just finished. It dropped the PSA down to, I don't even remember what it went down to. It went down pretty low, under 10. And as soon as I stopped chemo, it's going up again. And this past, let's see, 2 months ago, I started Pluvicto again. So that was going to be my talk tonight. That I've now had 3 more Pluvictos. This time I started Pluvicto at 20, and my PSA is now 10. The dry mouth has come back faster, but I've been using something called biotin, and the biotin works great in staving off and alleviating the dry mouth.
Okay.
Now I don't know that that works for everybody, but it's worked pretty well for me. Um,
Okay.
my big dilemma now is how many more sessions am I going to be able to tolerate? Because this is cumulative. I've had 9 already,
Yeah.
and no, I'm out. I'm out in no man's land. In
Wow.
your situation, I guess the question is, your PSA is still very low. How long do you let it go before you do something else?
Well, my PSA was always very low. When I got diagnosed, I was only 35, and I had mets in my spine and my lymph nodes, and it never really got above 35, and it's always been very low. And
So
but
your PSA, so your cancer is not really producing a lot of PSA.
no, and
Uh, the
but
PSA has always been a very good indicator for me. I seem to produce a lot of PSA.
yeah.
Um,
How about your eyes? Did your eyes get very dry?
um, a little bit. I use eye drops now and then, but the eyes haven't really been a big problem for me. It's been the dry mouth, and also related to the dry mouth, your sense of taste changes.
Okay.
Or at least in my case, the sense of taste was probably even a bigger problem than the dry mouth itself, because I could alleviate the dry mouth with with biotin and other things, but the sense of taste, there's nothing I could do about. I couldn't find anything to do about that um, until I stopped the Pluvicto.
All right.
Um,
Okay.
And
And
then
so,
how long
well,
was it
you
before?
have to know it's not a cure, but and And there's a differences of opinion as to when you should pull the trigger on something like that that has some side effects. Um, I did not have much problem with fatigue the first 6 I did, and I didn't have much of a problem with fatigue the first 2 this time. But this third time, I've had a real hard time with fatigue. And suddenly, a couple of days ago, it seemed the fog seemed to lift, and I've been feeling better the last couple of days. But it took more than 2 weeks for it to kind of abate.
How
Um,
long was it before your sense of taste came back after the first one, Al?
um, I should have taken notes on that, but I would say 3 months, 2, 3 months. The dry mouth it disappeared pretty much completely. The sense of taste came back. Um,
It's really frustrating when you don't want to eat your favorite foods, some of your favorite foods, because they just don't taste right anymore.
Okay.
But do I regret doing it? No. I mean, my PSA is lower now than it was in the middle of 2021. It's 2.5 years ago. Um,
Yeah. Is
but
did you have did you find that the Pluvicto was less more tolerable than the chemo?
um, much so,
Okay, good.
much so. The, the chemo and all the other stuff they give you besides the chemo and the steroids, and well, it really can knock you for a loop.
Yeah, yeah,
And those treatments were 3 months apart, 3 weeks apart, and the
right.
Pluvicto is 6 weeks apart.
Yeah,
Although the last one for me was 7, and this next one's going to be 7 too, just because of the way the calendar was working.
right,
Um,
right. Okay.
Well,
Well,
and
thank you.
also you forgot to mention you took a nice cruise and you went on vacation in between and all kinds of stuff, right?
Absolutely. España was muy bueno.
Hey.
So what about that question of when to pull the trigger? Does anybody have any advice or knowledge about starting Pluvicto when your PSA is low versus waiting? Do you take a terrible risk by waiting, or do you not?
Well,
Well,
Chuck, did they suggest that you have a second type of scan to check for concordance to see that you have PSMA positive and no or very little PSMA negative lesions?
Yeah, I did ask that question based on your suggestion last week, and she did say that was a very good question, and she was going to discuss that with my oncologist. But I did express, that thought it would be a good idea to get the FDG scan,
yeah.
PET
FDG.
So,
scan too.
Chuck, I think we told you this week. There's a bias. There's an innate bias with the radionuclide docs, and it was voiced by Tom Hope, who's probably one of the most respected and senior of all the radionuclide docs in the country. And their attitude is, well, let's just do it. The problem is they're not dealing with the guys where they just do it, and those poor so and so's get left with a whole bunch of crappy Mets that that didn't respond. And so, I think that a good oncologist, and I forget who is it that remind me who is it that you see at NYU?
It's David Wise.
David Wise. Yeah, I mean he's good, and I think somebody like David Wise is going to say to protect you. Yeah, let's verify that.
Yeah. Well, another, when I brought that up to the radiation oncologist, she pointed out that back in April I had a bone scan and a CT scan of my abdomen, and they looked okay. It was just the lymph abdomen or the abdominal lymph nodes were just glowing on the PSMA PET scan, so that's why she probably thought it wasn't necessary to get the FDG scan, but then I said, well, with the you get a better resolution with the PET scan than you do with the bone or CT scan, and she agreed with that. So
Which
hopefully
which
they'll,
is which
yeah.
is which is better? Um, how much inferior is MRI to an FDG scan in checking for concordance?
Oh, I don't know. That's above my pay grade. I don't know that one. Len may know it, but I mean, I do know that they almost always do the concordance with FDG. I mean, I can't tell you why, but Len?
But we're running across resistance, aren't we? Some docs resist doing the FDG scan. Maybe insurance companies are resisting it. I don't really know,
Well,
or Medicare. And
Well,
if the doc or the insurance company just refuses, uh, how much inferior is an MRI?
well, John, I think historically they don't like to use FDG scans for prostate cancer because it's a relatively slow growing cancer compared to the others. And FDG relies, it's radioactive glucose.
Glucose metabolism.
So, if your cancer cells are not actively metabolizing and sucking up the glucose, they may not show with an FDG scan. I wanted to ask you, Chuck, how are you just recently had chemo. What's the status of your blood counts, red blood cells, white blood cells, platelets?
They are on the low side. They are below normal. Yeah, still. The last
You
blood
know,
test I had, yeah.
because that'll likely take another hit from Pluvicto.
mm,
It does tend to suppress the bone marrow.
Yeah.
That's
Yeah,
just
that's a,
another consideration.
right, right. Yeah,
What
that's
about
yeah.
your BUN, creat, the measures for kidney function? They're good.
the most part. My blood work was normal, except for the red and white blood cell count. Uh,
Right.
yeah.
Okay.
I mean, I think that's a great point that Len just made. I mean, I was just looking yesterday at a gent, an older gent who desperately wants Pluvicto in Canada. He lives in Canada, and all of his blood counts, key blood counts, are low. Not a lot low, but marginally low. And so it really becomes the call of your medonc um, whether the Pluvicto is good timing. And I would rely more on your on Dr. Weiss's opinion than I would on Dr. What's her name, Doris?
Leithner.
Doris Leitner. I depend more on Weiss's opinion than Leitner's, because one of the things that we know, and we're going to focus on this in a webinar on Jan the 31st, is that the level of clinical knowledge for the radionuclide docs is not always as high as we would hope it is, because they just don't have the experience. And so, and there's sometimes a problem, because sometimes they don't want to talk to the med-onc. Sometimes they do. It depends on the politics within the organization. And I think that Dr. Weiss is going to have a better feel on whether he feels you're ready for the Pluvicto yet. I mean, he may want to see your blood counts come up a little bit. How long is it since you finished the chemo?
It was July 6th of this year.
You know, it's 3 months. He may want to see them come up a little bit more and trade off because he thinks the Pluvicto is going to be good enough. But that's such a good point that Len just made, and that's something that you have to be your own best advocate here, because you can't rely on Leitner, because she wants to administer. I mean, it's like a surgeon who wants to do surgery and a radonc who wants to do radiation. These radionuclide docs, they want to do their radionuclide stuff.
Yeah. Yeah. Good point. Well, another point that she made was that, she said that it's they have this drug reserved for me, and and if I wait, then it may not be available, because I know that
Oh,
there's a shortage, or it's probably
come
just
on.
an
That
excuse, right?
that makes me crazy. It makes me
Yeah.
crazy. Since when? Chuck, before you got involved with us last year, the beginning of this year, there was a real shortage of this drug, right?
Yeah, right.
We were in the middle of getting that shortage resolved, literally in the middle. We had over 100 guys who wrote letters to the FDA, and we generated those letters. And the bloody radionuclide docs did jack shit. Nothing. They did nothing. Their association did nothing. And
Yeah.
we worked with Novartis. We worked with the FDA. I'm not saying it's all us, but we were a real factor in that. And if these radionuclide docs can only turn around and tell you, oh, well, you got to get it because there's a shortage, you can give her my phone number. I'd like to talk to her. Since when? I'd like to know where that shortage is, because they're opening up a factory in Spain. They just opened up a factory in Italy. They're redoing a factory in Milburn, New Jersey that should be ready very soon. Just ask her, well, how many factories are producing now, Dr. Leitner, and see if she even knows.
Yeah.
That's bullshit.
Yeah.
I mean, I'm sorry, some things really trigger me. And when you get these doctors who try to sell you a bill of goods, the first thing that I say is they don't have the credibility. I worry about them.
Rick, this is Al. Do you think the hospitals get an allocation of this drug and they want to make sure they use their allocation, and so they're
Yeah, well,
pushing it?
yeah, but the thing now is that because it's something we got changed, we're able to switch around the allocations. In the old, and before the beginning of this year, they couldn't switch allocations. But now they have groups where they can move around. Because if you remember, one of the problems we had at the beginning of the year was that we couldn't get people to come in to get someone else's allocation. Everything had a name on it. So if it was a Chuck Snyder allocation, only Chuck Snyder could get it and it would get wasted. And we got Novartis to resolve that. So now not only do the drugs not have a name, they can be used for anybody in that location. If it's not just for Chuck, it can be for somebody else. But hospitals that are in the same group can move around the Pluvicto within their group. So I don't think they could move it to MSKCC, but they may be able to move it to other locations. And who knows if Leitner even knows that?
So in
That's
other
because
words,
go ahead.
don't decide on the basis that it might not be available in the future. Decide on the basis that it's clearly indicated, you are PSMA avid, the timing is right, and you're able to tolerate it. Those are the things that you have to
Exactly.
consider when deciding.
Exactly.
Were you reassured at all about what Al said about the tolerability of the drug?
Yeah, that was good, very good information. I kind of put my mind at ease, but
I mean, if you can tolerate chemotherapy, you can probably tolerate Pluvicto.
yeah.
Yeah, I think you can.
What's your alternative if the PSA continues to rise? What you'd probably do is, if you didn't want Pluvicto, you'd probably go on cabazitaxel instead, right? And you don't really want that.
Yeah, that was another suggestion by the oncologist. Um, another chemo. So I don't know. I'm kind of leaning towards the Pluvicto, but yeah.
Chuck, did
So
they Chuck, did they
uh,
talk about timing of, when is best to pull the trigger? Because nobody knows really. Um, and it's something I've thought too. I've got two doctors at UM. One told me to, be aggressive, and the other one told me to keep my powder dry until I really need it. So, but I've been going the aggressive way.
yeah,
Was, and
yeah. Like
but
I
you're
said, the PSMA was always very low, and the fact that it went from zero point 0.1 to zero point 0.6 in 3 months, it's a very rapid, 6 times increase, six-fold increase. even though it's very low, it's the degree of increase, I guess they look at, but I guess
So
that's
even
what
with
they were
a
concerned with.
even
Al,
with
you
a
And then
got
the,
the same question yourself, Al, right now?
Art,
What to do? You got the same question brewing for
well,
yourself right
you know,
now?
I had that question about when to start Pluvicto again,
Yeah.
whether I should do it sooner or later. Um, Dr. Belusic thought I was crazy to start it again so soon. But anyway, um,
Why? Why? Uh,
because he's not afraid of a rising, he's not so afraid of a rising PSA, I guess. Um, I didn't understand exactly what all his thought process was, but he didn't think, given where I was at the time, that it was the right time to restart Pluvicto. That my scans weren't clean, but they still had a minimum amount of disease, and he thought I could tolerate, seeing a progression of disease before I started it again. I have several lymph node spots, up and down in my thoracic region here and down in my abdomen, but nothing else. I don't have any bone. There's no bone. There's no organ. Um,
yeah,
at least not that the PSMA shows.
yeah, that's
So
exactly what.
he thought I could safely wait.
Okay.
So, but my
so
PSA was
what are you
rising
gonna do?
rapidly, and I feel better when my PSA is not rising rapidly.
Yeah.
Okay.
Um,
Thank you.
so I guess have a conversation about when the best time is to do it, and don't be pressured into starting it before you're ready. I mean, there's plenty of it out there, like Rick was saying. They may have one that they need to put a name on right at the. I suspect they had one they wanted to put a name on right away, and you were there and available.
Yeah.
I don't know. I don't know that. I don't know that, but maybe.
Al,
So
can I
what are
Um,
you gonna decide to do, Al?
Pardon.
What are you gonna decide to do?
Um, well, I have another PSA test next week, and I'm going to see what kind of effect of treatment number 3 or treatment number 9, um, how much of an effect that's had on my PSA. Um, if I've had another significant drop, I think I'm going to take a chance. I'm going to go for treatment number 4, but I can tell right now I'm not going to be able to do more than that the side effects are just going to get to be not worth it.
so
Um,
I want to address a question that Peter put in the chat, and it's a really good question that we've asked, and we've actually asked it to Michael Hoffman in Australia in a webinar, which is how much Pluvicto can you safely tolerate if multiple cycles are involved? Well, they've been doing these tests in Melbourne at Peter Mac with repeat, but they haven't published. They've told us they're doing them. They haven't published the results, but they have said it's very positive. So it seems like you can um, you can do repeat cycles if they're well spaced apart, and so this Pluvicto becomes something like chemo, where every so often you can do more and more chemo. You can keep doing the chemo, you can stop, you can start again, you can stop, you can start again. There will be information posted, but everybody's a little tight-lipped now because we've asked more than one person. And Peter, keep that question and definitely ask it to Dr. Sartor and Dr. Kuo in January when we do the webinar in January. and see if there's anything new that they can tell you. But it doesn't seem like it's a big issue, like in the way that using external beam is an issue, that there's a maximum, because it sort of gets absorbed and it gets dissipated, and then you're ready for more treatment. That's as much as we know, as much as I know. I mean, others may, even in this group, may have other input. And if you do, please chime in. I did want to ask Chuck if you spoke to Dr. Weiss about getting somatic testing, or if you'd had it.
You mean the what did you say?
The
Somatic?
genetic
Genetic.
testing on the tumor
The sequence,
material
not
itself.
the germ line, the inherited, but sequencing your tumor.
Yeah, I didn't discuss that with him yet, but I can do that.
I mean, to me, that was the most important thing to take away from last week's session for you, because
Yeah.
we don't know what your tumor has. And, when we're talking about, well, what else is there? And could you do something other than Pluvicto? Until we have a recent sequence of your tumor, which they can get from the lymph nodes. They can biopsy a lymph node, and they can do a soft tissue, which is the best, a soft tissue analysis. It may be that there are other treatments available.
I did have a biopsy of the lymph node. I want to say maybe a year and a half ago. Yeah, I did do that, but you're
And
saying that it
what
I'm
did they
sorry?
do with that? What did they do with that biopsy?
Well, they said I guess the concern was whether or not it was cancerous, and it was it was definitely metastatic. They thought it may possibly the lymph nodes could have just been
Right.
inflamed, but they weren't.
So,
They were cancerous. So
do you know if they sent it away for analysis, other than identifying that it was prostate cancer?
that's a good question. I don't know that.
So, in any
Chances
event,
are, yeah, go ahead, Rick.
a year and a half later, you're ready for another one, because
Uh,
the cancer can change. So, part of what Dr. Weiss, if I was Dr. Weiss, what I would be doing is checking to see whether you have any somatic mutations that are actionable in the event that Pluvicto is not a candidate right now. Or it may be a candidate, but you may have somatic mutations that might make something else a better candidate.
mm, okay. Okay. I'll ask him those questions.
Have we pretty much finished, Chuck, as far as we
Ye-
could go? We couldn't
Yes.
answer some of your questions because we don't know quite enough about things like when to pull the trigger and how much lutetium a person could have. But we hopefully have reassured you about its tolerability and got some information about monitoring your blood tests to make sure that they're adequate.
Yes.
And Al, how about you? Have we finished your discussion yet?
I think we kind of overlapped it with Chuck's. Yes.
Can
So
I ask?
I'll have more to say in a couple of weeks after I've had another PSA test, and I've talked to the doctor, and I also have a session with Dr. Schultz next week, and I'll get his input on it too. He has patients that have even more sessions than I've had, so he has more experience than well, my local doctors don't have anybody that they're doing a repeat session on, so they're totally not helpful from the question of tolerance, multiple sessions.
Mm-hmm.
I was also going to say, Chuck, if you want to talk to me any further, I'll put my email address in the chat box. Feel free to, pose
Thank
any
you.
more questions you have about it. Not that I have
Thank
any answers, but I can at least tell you how it's been for me.
Yeah, that would be very helpful. Thank you so
Okay.
much for your input, everybody. I appreciate
Mm,
it.
Can
Yeah,
I
no
ask a
problem.
question?
I don't
Can I?
think we have anybody else who has done Pluvicto on the screen tonight. Am I wrong? Is there any? If there isn't, is there anybody else who's done Pluvicto? We've got loads of guys, but I don't think anyone else is here.
Can I ask a general question? Can I ask a question to Al Latimer?
Go ahead, Jeff.
I see Chuck. I can't see you on the screen, Al, but I see Chuck. You're obviously a young man, and I wonder about the capacity to tolerate Pluvicto, multiple infusions of Pluvicto or docetaxel or cabazitaxel. And Al, can you give me sort of a ballpark figure how old you are and what your general health is, and you must be awfully resilient to be able to go through what you've gone through. So I'm just curious as a fellow.
I had a birthday yesterday.
Happy birthday.
Happy birthday.
I can't even say how old I am. How could I possibly be 75 years old? It's just not possible.
Oh, it slipped out.
75. Congratulations. Wonderful. You're resilient. How's your health overall?
My health is good.
No cardiovascular problems, and your white count, your red count, and everything.
My blood counts are a tad on the low side, but not any serious thing. My heart is fine, as far as I know. We just spent 2.5 weeks running around Spain and France and Italy, and I didn't have a problem until I come back and I took another dose of Pluvicto. So
you're amazing. I'm impressed.
But and understand, I started this when I was 47 years old. So, but one thing, I haven't had any Lupron in a long time. That stuff is nasty. I guess most people know I've been using estrogen to suppress testosterone rather than the Lupron. For me, it's been much better.
Thanks, Al. Okay.
I think I'd like to go on to Mark Valens now.
Oh, just a bit of an update. So I was on ADT for 3 years. I've been off for a year and a half. Starting in June. I've never had PSA. It's the highest it's ever been is 1.2, but it went down to undetectable. Starting in June, it started creeping up, and now it went from 1.2 to 2.5 in the last month, and so Dr. Borno at UCSF I'm scheduled for a PSMA a week from today, Halloween. So we'll see what we got there. I've been, even before that my PSA started budging, I've been really tired, even though I've been off the ADT for a year and a half. So I'm not quite sure what that's about. And then a whole separate set. Oh, go ahead.
Maybe your testosterone never recovered.
Oh, it's gotten up to, it varies from 300 to 500.
Oh, well, it did then.
But the other thing is the scarring from the radiation I had 4 years ago. I've been having all kinds of urinary problems, not being able to pee, having to pee every 20 minutes. So I've got a appointment November 11th, I think it is, with Dr. Breyer at UCSF, who's one of the top urologists. So I've got to find a way to pee because I'm getting up every hour and a half all night long. No wonder I'm tired.
Yeah.
But anyways, I just giving you an update, and I'll, a week from now we'll get the PSMA and we'll see what we have.
What else might be wearing you out so much besides poor sleep? Any other illnesses?
No, I'm a pretty healthy guy. And in fact, I'm a little surprised that I'm so tired without taking the ADT. So I'm just got my fingers crossed it doesn't have something to do with the cancer, but we'll find out.
Mark,
Can
can
you
you remind us of the treatments you've already been through?
So Mac Roach at UCSF gave me um, 8 weeks of radiation. Had 2 sessions of his CyberKnife, and then most of the rest of no 6 weeks, another 6 weeks of daily radiation, and then ADT with Lupron and Zytiga. No, not Zytiga, Xtandi. I didn't do very well with the Zytiga, and that's basically it.
Huh? And what was your Gleason score?
5+4. And I
Okay.
just this will be my first PSMA test.
Peter, you had a
Anybody ever?
question for Mark?
What's that?
Sorry, Len. I was going to
Go
follow
ahead,
up to
John.
somebody else that had a question, but I want to leave Len. Don't want to cut off Len. So could you
Okay,
remember
sure.
what you were going to say?
What about your your cell pathology? Was there anything unusual about that, or was it adenocarcinoma or something different?
No, it was adenocarcinoma and nothing, both genetic tests, nothing stood out.
Hello?
Huh.
Hey,
And yet you simply didn't produce PSA right from the start.
it's all right. I'm listening to a
Well,
webinar of my support
well,
group.
Dr. Roach said that some of the
No,
most
what's going
aggressive
on?
cancers never produce PSA.
Okay.
Well, I mean that is true. That some people are very low producers. In most cases, but not all cases, it usually means it's a more aggressive cancer. But I can also think of people like you, where the cancer took 10 years before we had to intervene. But in most cases, it is a sign, and that's something you can discuss with Dr. Borno. There's a couple of things that occur to my mind. The first is that when was the last time you had the somatic testing, Mark?
Uh, it's been it's back when I was down at UCSF, so that's like 3 years ago, 2.5 years ago.
So I definitely would discuss with Dr. Borno doing another somatic test to
Yes.
see what comes up if there's been any change. The other
Okay.
thing is, particularly in a situation like yours, um, you might want to ask her. I mean, UCSF in particular is really, really familiar um, with cancers that morph, that change, right? And what I would like to see, and she may be willing to do this, is I'd like to see you move over to Rahul Agarwal because, and I say that because she's trying to reduce her load because she's only there part time now because she's developing some new medical thing. You can tell her I said hello because we connected on LinkedIn and we've never had any sort of further conversations. But she knows AnCan, she knows who we are, and there are two real experts in this country right now on this morphing disease. And one is Rahul, and the other is Misha Beltran at Dana Farber. And I think that your situation might suit Dr. Agarwal a lot better because he's going to think about ways to make sure that it hasn't changed. the thing is that if it is changing, and it has changed, there are treatments. So if you read my reminder this week, I identified a trial that Rahul reported on back in I think it was like March, and then the trial actually got reported out last week, where they've had great success with people with morph disease. And if we can see that early and we can treat it early, we can deal with it early. And so even if she's reluctant to move you over to Rahul, but she may be only too pleased to do that because she's not taking new patients and she's trying to reduce her load. But if
She'll
not,
do whatever. She'll do whatever I want. The trouble is, I love her so much, I hate to leave her.
no, I know. Well, why don't you say, look, any chance that we could co-manage this with Rahul? Because
Okay.
you're like him too.
Okay.
He's got a similar manner, and she is lovely. And it was a big blow for us that we couldn't send patients to her anymore.
Okay.
But see if you can get Rahul. See what he thinks on your situation.
Okay. Sounds good.
Okay, and if you need me, I mean, you're going to do better with Halaborno than me. But if you need my help at all with Rahul, I'm happy to send him a note.
Okay.
Jim?
Excuse me, Rick. Could you explain something called a morph disease?
What I mean by
I
morph
know the
disease?
term.
Yes. Okay. So what we've known for some time, but it was first documented around 2015. I don't want to say it was first documented because Ben's corrected me on that, but the first time it sort of hit the big time and it was a big announcement was, in a conference at UCSF, their annual conference in 2015, when Eric Small and Rahul Agarwal reported that they had seen how these adenocarcinoma cells change their format and they come to look much more like neuroendocrine cells. And so what they say is, what the term they use is small cell neuroendocrine like, because they didn't start off as neuroendocrine cells. In a very small percentage of prostate cancer, it's about 1% or maybe less, slightly less, it does start off as neuroendocrine. We see it as neuroendocrine from the very, very, very beginning. But in other cases, what happens over time is that the cancer responds to the treatment and no longer becomes hormone dependent, and it starts to be more like neuroendocrine disease. And that's what we saw with Professor Herb, God rest his soul, and with Mike Yancey. And so the key is seeing that quickly. One of the big problems is that whilst we know that hormone sensitive prostate cancer can look very much the same in all metastases, doesn't matter where we take it from. If we sequence something from your pelvis and sequence something from your spine, they're going to look very, very similar. When you get this neuroendocrine disease, it can come in any place and it won't be everywhere. So we can sequence your spine and not see it, but we could sequence a lymph node and see it there. So it becomes very tricky to spot. But we just have our antenna up because we've lost some important people to it recently. And if you remind me, I can send you the papers, or if you just Google Eric Small, Rahul Agarwal, or Agarwal and Small and small cell prostate cancer, you'll come up with the papers. There's a bunch of papers. If I have a second, I'll put one or two in the chat window.
Thanks.
Richard, would you catch us up with what you've heard about Jonathan Epstein?
Oh, wait. Whoa, 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 whoa. Time out on this one. Because one of the moderators should be doing this
Okay.
because there's more information. And we had this situation yesterday where somebody didn't have all the information. Somebody in the group didn't have all the information. Peter, do you want to review what came out yesterday, and and Howard, both of Howard's posts?
Yeah, I don't have all the information either at this point. I haven't had the time to go back to Howard's posts and so forth.
I
It's
the only thing I have uh, was there was an article
In the
in the
Washington Post.
Sunday uh,
Right,
Washington Post, and
right.
I was asking the question, not trying to give you information.
Okay.
And that with
So,
that, I'll get out.
okay. So on Saturday, the Washington Post published an article on Dr. Epstein and Howard Walensky, who has who runs the blog, The Active Surveiller, picked it up, quoted the post, and made a number of comments. And if you go to the Active Surveiller, best thing for you to do, because again, I can't get all this down quickly enough, but go to the Active Surveiller, just Google it, and you can read both of Howard's. Everybody can read both of Howard's posts on this, including the article. So Google the Active. It's a strange URI. He's on Substack like Ben Nathanson, but this is what you need. Now, what it said was, as I'm sure Dick knows, that sometime, not didn't specify when, but that Dr. Epstein had pressured pathologists to change some of their readings, and particularly with respect to his wife's his wife's pathology reports, because his wife is also a pathologist, Hilary Ross Epstein. And now we should also say Dr. Epstein is on our advisory board. So I have to state that. So there was a lack of credibility in Dr. Epstein's reporting. And Dr. Epstein, I believe, responded to the Post or responded to somebody because this was bought by the Joint Commission and also and the Joint Commission of Hospitals. Dr. John will know what the Joint Commission is, but apparently it was the Joint Commission and also Johns Hopkins. And what he said was it might have been an error in his judgment to comment on his wife's report, but there was certainly nothing wrong with what he was saying medically. And by the way, for those of you who don't know, he was asked to take a leave of absence in May, and nobody knew why until last weekend. And they kept it very, very close to the chest. Not even Howard could find out. And so that in summary is what the Washington Post said, that he was found to be pressuring people with respect to his wife's results. And it wasn't just that, it had happened in other situations, but they were very unclear. So yesterday, Howard wrote an open letter to Johns Hopkins, encouraging them to disclose a whole heck of a lot more information, because he said that there were many patients who are now in doubt about the results that they have received that have been signed by Dr. Epstein, as to how extensive this problem was, how many times it happened, when it happened, what diseases it was with respect to, and that if you had any questions, he gave Dr. Epstein's email address, and he gave the chief medical officer at Hopkins email address, and encouraged people to write to them directly. And if you go to the active surveiller post, you'll find all that information there. So I had had a minor skirmish for a change with Howard, because there was a JAMA article last week having nothing to do with this that I felt needed a response. And I wrote the response and asked it to be Howard and I to send it in together, and also somebody from veterans. It applied to the VA, and Howard, without asking me, ran it past Stacy Loeb. And Stacy said, "No, you're misinterpreting what's said." And I knew what she was going to say, which is why I didn't ask her to sign it. And so it put the whole kibosh on us sending that in, because I don't want to directly confront Stacy, because she's also on our advisory board, and it's bad. So when I saw what he'd written on this Epstein thing, and I hope you're all following me, I said, well, did you run it past Dr. Epstein before you published this? Because he seems to be very good at running things past people. And he said, no, he hasn't spoken to Dr. Epstein since this all blew up.
Oh.
So Howard can be a bit of a loose cannon, and he can sometimes, and I know this is being recorded and it's fine, but he can be a bit of a loose cannon, and I find myself sometimes hauling him in. And in certain places, where it suits him, he can run things past people and do his due diligence. In other places, he doesn't do it. And I personally am bothered by what he wrote yesterday, this open letter. Thank goodness we were not a signatory to that, and we were not mentioned in that, because I wouldn't want to offend Dr. Epstein. At the same time, I'm happy to go on record as saying that from AnCan's point of view, I think that there was it was an ethical misjudgment on the part of Dr. Epstein to review his wife's work. And Howard asks Hopkins, why on earth did you allow Dr. Epstein to review his wife's work? You've got to explain that, which of course they haven't done yet. They may never do. But in my view, I think it was Dr. Epstein's error, and he should have told his wife, I can't do this. I can't review your work. But he didn't. And now it's all blown up. So that is what I know. And if you guys read the 2 blog posts and the Washington Post article, you'll know as much as I do. And let it be known that Howard doesn't know any more than what's written. So that's where we are. If it were me, I would not be questioning the opinions that Dr. Epstein issued on biopsies, my biopsy slides. It wouldn't bother me at all. But there are other people who it may bother. If you are bothered and you want to get slides reread again, we can suggest you send them to Dr. Zhang at Tufts. Dr. Zhao Ming, I should say, Zhao Ming at Tufts, and we can give you that information, and Howard will provide that information. You can send them to Dr. Epstein's lab, because his people are well trained. And I think there are a couple of other options too. So That's the Epstein. That's the Epstein
So
update.
I just scanned. There's also a New York Post article about this. Um, it's a little more extensive that came out yesterday. And in it, Dr. Epstein makes a comment about the accusation of conflict of interest and denies it. And he does it in such a way that makes me think that he reviews, he gives second opinions on pathology, probably blind, without knowing what pathologist might have read this, is my take on it. It doesn't say that specifically, but
Okay.
that's the way I read in between the lines. So it might, he's saying there's no conflict because he's just doing second opinions of other other pathology reports. So it might not, it might just be at random and he doesn't know who his wife's take is. But I'm just
Well,
guessing at that.
yeah. I mean, the problem is that the allegation is that he pressured other pathologists to change their opinions on his wife's results. Now,
But that's
it could be
allegations, you know.
that those are the allegations exactly. Now, it could be that he didn't know that whoever read them the first time was his wife, and if that's the case, he needs to come out and say it. And
He
he never
seems to
knew.
imply that, but
Okay.
in the quote he made from the post, but it doesn't elaborate on it. It just says there was no conflict. He doesn't feel there was conflict of interest because that's not how he worked. But I don't know. I don't know. There's more to come on this story, I guess.
Yeah, there is. And could you put the New York Post article in there too, please, Peter?
Okay, I'll see if I get it
Thank
again.
you. Thanks.
The other thing I noticed in the Post article was that they said the commission had not interviewed Dr. Epstein. So, that was a big hole in terms of what they could report. So I noticed that in the article.
Um,
One thing, I'll just interrupt. The reason I came on to ask the question is he going to be getting back to his research? I'm not trying to report on any of these
we don't
newspapers.
know. We don't know.
For the
We
simple reason his research is probably somewhat unique in this country on the foamy gland.
we don't know. We don't know, Dick, because we don't know what the outcome is going to be. I would say this, that if you have issues around your foamy gland, that if you contact him and we can provide ways other than the Hopkins email address to contact him, I feel sure he'll respond to you. I would bet I would bet dollars to donuts he will respond to you, and we can put you in contact with him. But I don't think anybody
I
knows
would
what
be
yet.
interested because 3 months ago I did try contacting him about questions on the paper he wrote, and I haven't gotten a reply yet. But I was not aware that he was suspended as of May.
Yeah. Did you contact him? Did you contact him via his Hopkins email, or did you contact
Yes,
him out? Then
Hopkins.
he hasn't responded to anything there because he's suspended right now.
That's probably the reason I haven't heard from him.
But we're happy to help you. I mean, I sent him some Jewish New Year's wishes, and he responded right away to thank us. And that was last month. So and I didn't pursue that, but I thought it was nice of him to respond to say thank you because most people didn't. So. And I just hope that we resolve this, like Peter says. I hope there's more to it. I hope we can resolve it. Howard Walensky in his open letter says don't you think that Dr. Epstein deserves the opportunity to stand up and defend himself to the Joint Commission? In just as a comment on what Gary said, and we would agree with that. So there's more, as Peter correctly says, there's more to come. Oh, he's getting undressed there, Peter. Watch out. Okay. Oh, close your camera, Peter. There you go. Okay.
I got a couple minutes left to see what Jack wanted to bring up tonight.
Okay.
Well, it's just a couple of questions. I wanted to ask one or two questions in particular because we've talked a lot about bone health and people who have bone metastases, and I was reading something or hearing something on a webinar about prophylactic utilization of either extra calcium or D3 boron or whatever to build up the bone prophylactically, preemptively, and also the various drugs that are used, Xgeva and other drugs like that, preemptively before you end up inevitably to some degree getting at least osteopenia, if not osteoporosis. And I wonder if anybody has done that or waited until their DEXA scan exhibited definite osteoporosis, and then only then after that went ahead with treatment or giving. And how dangerous is extra calcium when you have some bone mets? And I wonder what your thoughts are on that.
My particular oncologist preemptively put me on calcium and vitamin D when I started treatment. And Gary, did you? No, let's see. Oh, Dennis. Dennis, you had something to add.
Yeah, I was going to say the same thing. As soon as I got my initial diagnosis from the urologist that did the biopsy, he recommended the calcium and D3, and I've been on it for 6.5, 7 years without a
I've
problem.
taken small amounts of calcium all along for many years, but how high can you go with the calcium? At what point does it become risky in view of the metastatic disease?
I think that I remember hearing a nutrition lecture about calcium and prostate cancer that suggested that there is an actual increase or encouragement of prostate cancer by calcium when we take more than something like 1,800 milligrams a day or a couple of grams a day. And that particular lecturer suggested that we take 500 or 600 milligrams twice a day with food, but not go beyond that.
Makes sense. I heard something like that too. That's the reason I wanted to hear from you guys. The other thing I wanted to ask.
So hold on a minute. Hold on a minute, Jack. There are old papers which I uncovered back when I was diagnosed in 2007 and 2008 that there is a correlation, not an explanation, but there's a correlation between high levels of serum calcium and more aggressive prostate cancer.
Yeah.
Now, it's possible since then there's been an explanation of how that came about. I don't know it. I was interested because I've always had very high levels of serum calcium, and that runs in my family. And I have calcium deposits about any place you want to look. And my sister has worse calcium deposits than I have. The only difference is she doesn't have it in her prostate. She doesn't have any calcium deposits in her prostate. But I did have calcium deposits in my prostate. So I've always taken high vitamin D. I've never supplemented my calcium because I figure I already have too much. At the same time, it might be a result of my body leaching out of my bones, and maybe I should be replacing the calcium, so I should be adding more. So I don't really know the answer to that. Although I was osteoporotic at age 56. So That's the input I wanted to provide.
Are your calcium scores above the normal range, Rick?
Yeah. Never that much, but always a little bit. Like 1 to 2 points over. Never enough to worry about, but just always a little bit more than always. Always between about 0.5 and 1.0 over the upper limit.
All right, in addition to the bone building routine of calcium, D3, and boron, and silicone, all the other stuff they recommend, what about actual medication, denosumab or Escheva, things that some of you had taken, like Len? Preemptively, anybody take it before they got diagnosed with osteoporosis?
I've never heard of that happening.
Okay. All right.
Anybody else, though? I might not have.
Well, they do give they give Prolia, which is a lower dose denosumab, to women postmenopausal to prevent
I know that.
Right.
osteoporosis.
So that's the reason I asked. I was wondering.
Yeah.
I know they do that with women. The other preemptive question I wanted to ask is, all of you who have been on Pluvicto or docetaxel, I don't know, I may have to someday, I'm not sure, I don't think I will, but because I'm a little old and I'm not sure I could tolerate it like Al Latimer or Chuck Snyder. But I wonder about prophylactic Neulasta. And, I was listening to Mark Schultz, interesting guy. I know some of you use him, know him. And he was talking how frequently he gives Neulasta to people prophylactically before they start the chemo. I don't know if they do with Pluvicto as a way of preventing infections, or white count drops drastically and things like that. Is that something anybody? I know, Len, you may have mentioned Neulasta once, but I didn't know if it was in reference to the specific conversation I'm having right now.
Well, what I do remember, Jack, is that did you know Snuffy Myers, Dr. Charles Myers?
Didn't know him. I heard of him.
Yeah. He was a director of pharmacology lab at the FDA, and then he became a prostate cancer guru who never accepted insurance. You had to pay him in cash. But anyway, he would routinely prescribe Neulasta to guys with metastatic prostate cancer, just part of their regular therapy. I can't recall exactly how often he would give it to them, but he's the only one I'm aware of that did that, apart from chemotherapy treatments.
Well, Mark Schultz does it. His most recent lecture I just listened to the other day, and he was talking about he does that routinely, in addition to the Prolia and whatever preemptively.
Okay.
And I listened to a couple of them this week, and the other one I briefly spoke to Rick about. I wanted to talk about again is the infamous Eugene Kwan, who famous and who again talks a lot about. He talks, both Schultz and Kwan talk about the word cure, which is anathema in this group, of course. And I don't know. I think the perspective of Schultz is more of a religious, spiritual kind of a approach to it, because I understand he's a very religious, spiritual man who believes in miracles. And he talks about patients who, in spite of all odds, advanced cancer, who came out clean in the end and disappeared. And, it's always nice to know there's a possibility. And I do believe in hope, if at all possible. And it's a nice thought, even though it may not be realistic. And Eugene Kwan talks about it all the time. And he talks about how they cure from left and right. And he talks about it from the perspective of great medical acumen coming out of Mayo, where they got, every possible type of, modality that they can utilize to really, get rid of whatever you have going for you. But he uses lots of very aggressive approaches to everything, especially triplet from the get-go. So I was wondering about triplet from the get-go. We don't talk about it all that much here. We hear about it as ultimately something that one gets after something fails. But under what circumstances do we get triplet from the get-go in order to have a better result?
Well, first of all, we've seen enough guys who have gone to Quan where he hasn't used triplet from the get-go. So what he tells you may not be what he actually does, because I've got examples of it, and I can think of two right off the top of my head. He didn't use it. Secondly, I can also give you examples of men where he held off giving chemo because he doesn't give chemo. He's not licensed to give chemo, and he doesn't refer people to Rochester, Mayor Rochester, to give chemo. He sends them to his cronies in other places. I shouldn't say cronies; they're probably good doctors, but they're buddies of his. And we have a young fellow who's done very well by getting the chemo and still sees him. A young guy in his 40s in Chicago, who's a Quam patient and has gotten his chemo in Chicago. So, but he didn't get it right away, and he didn't get. It wasn't. I don't know if it was triplet or not. I'd have to look it up. So that's my first point. My second point is that Snuffy used to talk about this issue around cure. And what he came up with, as Len will well remember, because Snuffy kind of preceded Dr. Schultz. Schultz was around when Snuffy was around, but Snuffy was kind of the senior partner. And Snuffy used a lot of the strange combinations that the NCCN hospitals weren't so happy in doing. And he used to talk about, he said, you can't cure this disease. The best you can do is you can get a durable continuing remission. Durable continuing remission. And that's different from cure. Is it like cure? Yeah. It's very much like cure. Because you don't have to treat it and you're in great shape. But does it mean it'll never come back? No. Does cure mean it'll never come back? Yes. So my question to somebody who uses the word cure, like Dr. Kwan is, would you put 100 grand down in my bank account and I'll promise to give it you back? I'll promise to give it you back if the disease comes back. How sure are you of that cure? 100 grand? 50 grand? 500 grand? How sure are you? Put your money where your mouth is. And then we'll see how quickly he uses the word cure. Because right now, we don't know anybody with advanced disease that we can truly say they're cured. And the reason for that is because we can't see the micrometastasis.
You
Unless
just don't
Dr.
know
Kwan,
until they die,
yeah, and
right?
right. I mean, when maybe you biopsy them, and when they die, there's prostate cancer, and then we don't know it. So where this bullshit comes from with Dr. Kwan that he can cure the disease, I don't know. But make him put his money where his mouth is.
I think in the interest of time, I'm going to bring that discussion to a close if I can and let Dennis Correa have the last word other than me.
Thank you.
Dennis, you got your hand up?
No, not that I realized. I already spoke.
Okay.
Okay.
I would like to know. I would like to hear, because, and I'm open to be contradicted by anybody in this room. But that's my opinion. I would like to hear what Len says, because Len's been around these docs not quite as long as me, but he's been around these docs longer than anybody else that's in this group right now, other than me.
Yeah, well, for someone like me, Gleason 9s, they tell you, particularly if it's in any way gone beyond the prostate capsule, though several oncologists I've spoken to have said, you're not curable, but we can treat you. And I think I spoke to Peter about this once because I had listened to Dr. Schultz's YouTube video about Gleason 9. I think it was actually addressing Gleason 9 prostate cancer. And he stated something like 70%. I don't know if he was saying he can cure or it's possible to have a cure of 70% of Gleason 9s, which, I said to Peter, that sounds awfully suspicious to me. And I don't know, did you ever talk to him about that, Peter? No?
No, no.
Yeah.
I can't remember that conversation.
Okay. So, yeah, my opinion is in line with yours, Rick. If you've got advanced prostate cancer, I don't know, psychologically, if you want to think about cure, fine, but realistically, you just don't know. And all you can really hope for is a long-term durable remission, which feels like, I guess it could feel like a cure.
And then to answer Jack's questions about the indications for triplet therapy, I think, correct me if I'm wrong, it would be somebody with a high, somebody with Gleason 9 or 10 or advanced prostate cancer who may be even hormone sensitive still, but who has a high tumor burden, might be considered for triplet therapy quite early on in treatment even. Is that correct, you guys?
Diagnosis. I mean, the triplet recommendations, if you look at them, all tie into that they're all for people who are de novo metastatic with a high, with a multiple lesions, not oligometastatic. That's where triplet comes in, because we had a situation, if you remember, with Steve Schneider just recently, where he has recurrence and was talking about doublet and triplet therapy. And I looked at it at that time. And most of this doublet and triplet therapy is used in the context of diagnosis. But what's actually happened in reality is that now, even on recurrence, doublet therapy is invoked. And on recurrence, most of the time, triplet therapy may be invoked if the recurrence has high levels of metastasis, but not on follow up. So if you're following up from previous treatment, and they found that that you had lymph node involvement or even a metastatic lesion on after surgery, for example, or radiation, then they're not necessarily using doublet or triplet.
This also reminds me of something that I think I'd like to put in one of my invitations sometimes. If any new guys hear the name of a person, the name of a drug, the type of a therapy, a study, anything that you don't understand, pipe right up. We don't want anybody to get left behind in the conversation. So I had a hard time when I first came here, so don't let anything go by that you don't understand. I think with that, I'd like to thank everybody for coming and participating so actively. We talked about a million things tonight. And I'd like to close the group. Good night, everyone.
Good night, everyone.
Thank you, John. Good night, everyone.
Bye-bye.
Bye.